Welcome, and thank you for joining us today. Please take note of the disclaimers in place for today's presentation. The learning objectives are the following. Understand the background and rationale of enhanced recovery after surgery. Be able to describe the key elements required for a successful ERAS program. And summarize how ERAS implementation can help to address the COVID-19 related surgical backlog. Our speaker today is Dr. Nelson, Professor and Chief of Gynecologic Oncology, University of Calgary. Dr. Nelson is a professor of obstetrics and gynecology and oncology at the Cummings School of Medicine and is section chief of gynecologic oncology at the Tom Baker Cancer Center in Calgary. His main research interest is the development and study of ERAS protocols in cancer surgery. He holds a position of surgical lead, ERAS Alberta, and is also secretary of the ERAS Society. With that said, I will now pass it over to Dr. Nelson.
Thank you very much for asking me to present today on principles of enhanced recovery after surgery, or ERAS, and also why now is the time to implement ERAS to address the COVID surgical backlog. I have no financial disclosures to report. The objectives of today's presentation are to be able to understand the background and rationale of enhanced recovery after surgery. This will be a ERAS Basics 101. I hope that people will be able to describe the key elements required for a successful ERAS program. And at the end, I hope that viewers will be able to summarize how ERAS implementation can help to address the COVID-related surgical backlog. So I think it's important that everyone has a good understanding of the background and rationale of ERAS. When we think about recovery after surgery, what are we trying to achieve? Essentially, we all want our patients back to, at minimum, preoperative level of functioning or better. We want normal gastrointestinal function. We want good pain control in our patients. We want them up and moving around. And most of all, we want no complications. This does need everyone's help, all those that are involved in the patient's care. So this includes surgeons, anesthesiologists, nursing staff, nutritionists. We want to get the patients and their support people involved as well, and also hospital managers. So how do we actually achieve this? I believe the answer truly is enhanced recovery after surgery. So let's take a moment to talk about what this actually is. In the early 2000s, a group of European surgeons started to question the evidence behind some of the historical practices, such as NPO after midnight, or what we would call some dinosaur practices. And this essentially led to the development of a society, the so-called ERAS Society, that has as its mission to develop perioperative care and to improve recovery through research, audit, education, and implementation of evidence-based practice. And when we talk about evidence-based practice, we're talking about guidelines, and that forms the basis of ERAS. ERAS today, as we know it, there is being practiced in over 170 units in over 25 countries across the world, and this is growing. So this truly is a global surgical quality improvement initiative. As I indicated, ERAS is based on guidelines. This is one of the first guidelines that was developed for colorectal surgery, but as indicated in the list here, there are many, many guidelines that are being created. This list is growing. We now have guidelines also in cardiac surgery, spine, and also many more in the development phase. So this schematic shows basically all of the standard ERAS elements broken down into preoperative, intraoperative, and postoperative periods. And really the majority of these elements have as a common goal to decrease the stress response to surgery. I used to say that ERAS was about making radical changes, but I think we've gotten to a point now where it's really just about making changes. I often ask those in the audience to take a few seconds to look at all of the components and think to yourself, which are the components that you're already practicing? Which are those that you think that you could maybe make a change starting tomorrow? And which are the ones that you really feel uncomfortable changing to? So it's good to kind of get your own sense of where you are on the ERAS scale. So a number of individuals over the years have said that maybe ERAS is crazy. I'm not so sure. So if we look at this group of elite marathon runners, imagine them preparing for their marathon by having a 2-day bowel prep, only being allowed to have clear fluids the day before, having nothing to eat or drink after midnight. I would think that we would call that crazy. So major surgery has been suggested to be like a marathon for patients, particularly in terms of the stress that it causes. So why are we not asking our patients to prepare for their marathon? We should take some time to discuss some of these ERAS elements, particularly the core concepts. So as I alluded to, ERAS is based on a number of elements that share a common goal, which is to attenuate the surgical stress response. ERAS elements lead to homeostasis, which allows the patient to avoid catabolism with consequent loss of protein, muscle strength, and cellular dysfunction. And it also helps to promote reduction of insulin resistance, which ultimately promotes adequate cellular function during tissue injury. When we look at, again, some of the core concepts, one of the main things that we like to do is to help people come into surgery in the best possible state. So when we look at pre-admission optimization, there are a number of components, including smoking cessation, avoiding alcohol abuse, which we know is associated with, stopping those practices is associated with a reduction in complications. Patients should be screened for malnutrition, and if found to have lost more than 5% of body weight, should be given nutritional support for at least 1 week before surgery. If patients are anemic, they should be given iron substitution. And there's this new concept of frailty that has been identified in the literature. And if patients meet a frailty index, and if time allows, should be given some form of prehabilitation, preferably 4 to 6 weeks before surgery. And prehabilitation typically involves exercise, nutrition, and a psychological intervention component. Carbohydrate loading and avoidance of prolonged fasting, again, are key tenets of ERAS. So as I said previously, the NPO at midnight rule is a practice that is largely unsupported by high-level evidence. There is evidence supporting safe practice of intake of clear fluids until 2 hours before the induction of anesthesia, as well as 6 hours for solid food. Carbohydrate loading specifically is ingestion of a 50-gram complex carbohydrate drink. And in major abdominal surgery, this has been associated with a reduction in insulin requirements and less hyperglycemia. It's also been shown to improve patient well-being and decrease nausea and vomiting. Mechanical bowel preparation is a controversial area. Mechanical bowel prep, regardless of your view on this subject, does have significant adverse side effects, including dehydration and patient distress. Recent large meta-analysis in patients undergoing elective colorectal surgery showed that the use of mechanical bowel prep versus no mechanical bowel prep was not associated with any difference in anastomotic leak rate, surgical site infection, intra-abdominal collection, mortality, reoperation, or hospital length of stay. Recently, there's been some discussion around the role of oral antibiotic prep with or without mechanical bowel prep. Again, the studies are showing mixed results, so this is really has yet to be clearly defined. But in general, ERAS programs advocate for the avoidance of mechanical bowel preparation. Avoidance of nasogastric drainage is another key area. We know that NG Tubes result in significant patient discomfort with little clinical benefit. Again, a large meta-analysis showed that patients undergoing major abdominal surgery found that those without routine NG use had a decrease in time to resumption of bowel function, a reduction in pulmonary complications, and shorter length of stay. And they found no difference, again, in anastomotic leak rates. One thing that people need to realize is that many of these practices historically were targeted towards trying to decrease bowel anastomosis rates, which obviously can be very devastating, but none of these practices have been shown to bring that about. Postoperative ileus is a major complication of abdominal surgery and can impact up to 25% of patients. One of the main ways that the ERAS program helps to prevent that is to avoid narcotics. So we typically like to employ opioid-sparing multimodal analgesia techniques because we know that opioids slow the bowel down. Historically, chewing gum has been included in most ERAS programs. Obviously, this is a low-risk intervention, and many patients like to chew gum after surgery. Recently, however, a large RCT showed no benefit. There has been some promise with mu opioid receptor antagonists such as alvimipan. This has, mechanistic promise given the fact that it targets this receptor without reversing analgesia. The studies, again, are mixed regarding this, and alvimipan is not readily available in many countries. Maintenance of euvolemia, again, is also one of the key ways to prevent postoperative ileus. Traditionally, patients would have or given lots of saline-based fluids that can result in slowing of gastric emptying and delay of bowel movements by 2 days. So again, leading into maintenance of fluid balance, we know that overload of fluids is associated with increased complications such as bowel edema, heart failure, but we also know that giving too little fluid is also not good, and that can be associated with kidney injury. The current recommendation, according to most ERAS programs, is to keep a balanced fluid regimen to maintain body weight within 2 to 2.5 kilograms weight gain after surgery. And one of the key concepts is that patients are encouraged to drink freely as soon as possible when lucid after anesthesia, and that IV fluids are typically stopped the morning after surgery, especially once patients are demonstrating that they can tolerate 600 to 800 cc's of fluids. And finally, early feeding, again, is a key concept. So we know that withholding solid food from patients until passage of flatus is not evidence-based. Neither is advancing diet from clear fluids to full fluids. We know, in fact, that introduction of solid food as early as 4 hours after bowel surgery has been shown to be safe. And delay in resuming normal diet after major abdominal surgery is associated with increased rates of infection and prolonged recovery. So basically what we're trying to do is we're trying to avoid having a bunch of patients on the ward starving after surgery, and especially, it being safe for them to have this. So we've talked about some of the basics of ERAS. Now, what about, does it actually work? So specifically dealing with outcomes. As I indicated, the first ERAS guideline was in colorectal surgery, so definitely the majority of the evidence base to date is within this discipline. This was one of the first meta-analyses that was performed that showed that formal ERAS implementation basically resulted in a reduction in length of stay of 2.5 days. They also were able to show a reduction in complications by 50%. There has been a lot of talk about the importance of ERAS compliance. So as I showed previously, a formal ERAS program includes upwards of 20 to 25 elements. And so some have expressed concern that starting a program, there can be a lot of effort. So, is there just a few elements, or can we use half the number of elements to affect a change? This particular study looked at over 1,500 colonic resections, 843 rectal resections. This was a multi-center international study, and they showed that increasing ERAS compliance correlated with fewer complications and shorter length of stay. So this was the first study to identify a dose-response relationship, essentially showing that you need to be compliant with as many of the ERAS elements as possible, and by doing so, you will see a reduction in length of stay and complications. So I'd like to give you some perspective on how we got started in Alberta, and this is particularly relevant for those who might be wanting to start their own program. So as many of you are aware, Alberta Health Services has one health system, lots of people, lots of employees, many doctors, and of course a huge budget. So it's probably no surprise to you that with such a large organization, as with others, we are constantly looking for ways to bend the cost curve. In our province, we have what are called strategic clinical networks, which are essentially engines of innovation. And the diabetes, obesity, and nutrition, together with the surgery strategic clinical networks, in 2013 decided to take a chance on enhanced recovery after surgery in our province. And we started off with a proof of concept project where we implemented ERAS in colorectal surgery in 2 hospitals. And essentially they hit it out of the park. So in 690 patients, they were able to show a reduction in length of stay of 2 days, fewer readmissions. And when we did a formal health economic analysis, this showed net cost savings of between $2 to $4.5 million. Fast forward to a larger cohort now in more patients, more hospitals, and again, health economic evaluation now showed that net cost savings was between $4 to $8 million, with a return on investment ratio calculated of almost 4. So for every $1 invested in ERAS, we were able to get $4 back. This got the attention of our executive leadership team in the province at AHS and ultimately led to approval for spread of more pathways into more sites. So now we have formal ERAS programs in our province in colorectal, HPV surgery, urology, head and neck cancer, breast reconstruction, and OB/GYN surgery. And it's a really good example of how ERAS success in one area can extend to other surgical areas. So I'm a gynecologic oncologist. Basically, I do gynecology, urological surgery, bowel surgery. So let's take a moment to look at the evidence supporting ERAS in this discipline. In 2014, some colleagues of mine at the Mayo, we looked at the landscape of enhanced recovery pathways in gynecologic oncology. We were particularly interested in determining if there was a reason to develop guidelines in our specialty. This is, there are a few busy slides here, but the main purpose was to really show that when we looked at the evidence at that point for ERAS in gynecologic oncology, there were many mixed populations in the literature, some with cancer, some non-cancer populations, some complex surgery, some minimally complex surgery. When we looked at the ERAS programs that were described, they had inconsistent enhanced recovery elements. So you can see that in some cases, the programs had very, very few elements. In some programs, they had quite a number of elements. And in the end, our main conclusion was that it was very difficult to compare the results across these programs. And we concluded that there was a need to develop a formalized evidence-based guideline for patients undergoing surgery for gynecologic cancer. This ultimately led to the development of the ERAS Society Gynecologic Oncology Guidelines in 2016. So I had the distinct pleasure to lead this international group. And these guidelines, there has been significant interest and uptake. These guidelines have now been downloaded more than 70,000 times. When we looked at the evidence in the preoperative, intraoperative, and postoperative periods for gynecologic oncology surgery, what we found is concepts that were very similar to that I showed you earlier in the talk for colorectal surgery. So we found evidence to support avoiding bowel prep. There was good evidence to support carbohydrate loading, the modern fasting guidelines, which was the 6 and 2 rule, not using long-acting sedatives, giving DDT and antibiotic prophylaxis, aggressively giving postoperative nausea and vomiting prophylaxis. So patients undergoing gynecologic surgery are particularly prone to nausea, so this was one that was very important. Not using NG tubes, aiming for euvolemia, and also keeping the patient warm. In the postoperative period, again, we found evidence supporting early removal of the IV, promoting early feeding, stimulating the gut, not using any form of peritoneal drains. Again, multimodal opioid-sparing analgesia. So historically, patients who had open surgery would be receiving a PCA or patient-controlled analgesia, and very few of our patients ever need that anymore. Removing the urinary catheter right away, and of course, getting patients up and walking around through active mobilization programs. We have since updated the ERAS Society guidelines. These are now published in the International Journal of Gynecological Cancer, these guidelines are available for free at this particular website if you're interested. So I showed you earlier that there was evidence for improved outcomes in the ERAS colorectal surgery area. And how about the guidelines that we just developed? Is there evidence for those? So this was a provincial study that we undertook looking at the impact of the ERAS gynecologic oncology guidelines. And I'll just walk you through the results. So we had 152 patients in the pre-ERAS, so this would be the conventional perioperative care group, compared to 367 patients in the post-ERAS group. These patients had both debulking, so multivisceral resection cases, including bowel resection, splenectomy, that type of thing for advanced ovarian cancer, and also organ-confined staging cases. One of the key things that we like groups to do is to describe their protocol. So this was the protocol that we used. Again, a bit of a busy slide, but really the main take-home point is that everything that we did mirrored what the ERAS gynecologic oncology guidelines said that we should do. One of the other key metrics to report in your program, and if you're planning on publishing, is to report on the compliance to the protocol. So many people internationally think they're doing ERAS, but when you actually audit your baseline performance, typically people are in the 40 to 50% range, and we were as well. So our baseline ERAS compliance was 55% overall. And over the course of several months, we were able to iterate towards improved ERAS compliance and ultimately ended above 76%. And I have highlighted the areas in the red asterisks, which are associated with statistically significant improvements in ERAS compliance elements that we achieved. Some of the main outcomes overall, we saw a reduction in median length of stay from 4 days to 3 days. For the low complexity surgeries, this went from 3 days down to 2 days. And one of the main achievements, especially for the multivisceral resection patients, we actually started off at, we were doing quite well already, and there was some skepticism as to whether or not we could make improvements. But we did, in fact, see a reduction in length of stay for the high complexity surgeries from 5 days down to 3 days. Another important findings was that we demonstrated a 17% decrease in complications in these patients. And these were some of the main areas where we showed reduction in complications, so in respiratory, cardiovascular, a number of gastrointestinal complications also, and reduction in transfusion. We were also interested in looking at some other outcomes such as fluids, diet, and pain control. So we were able to demonstrate reduction in fluids given intraoperatively and also on post-op day 1. We also found a reduction of time to tolerate first solids from 2 days down to 1 day. And another important achievement, especially in the setting of the North American opioid crisis, we showed that time to pain control on oral analgesics only was reduced, and we also found an overall reduction in opioids given. So this is, I think, really good. However, at the end of the day, we need to talk about patients. These are the ones that truly benefit from ERAS. This is an actual patient of mine, Mrs. JT. She's a 65-year-old lady who had recurrent ovarian cancer. We did a major debulking surgery for her, which included a bowel resection. So she had no patient-controlled analgesia. She did not receive an epidural. So I placed the transversus abdominis plain block or tap block myself. She had scheduled meds only. We gave her a regular diet on post-op day 0. She did not have any drains or NG. And she said to me, "I just can't believe how much better I feel compared to my last surgery." Now, interestingly, I did her last surgery. That's when she presented with advanced ovarian cancer. At the time, we did not have an ERAS program. So this patient really served as her own internal control. And ultimately, she was home on post-op day 4 and had no complications. So this person always stands out in my mind as being someone who really was one of the poster people for this program. There has been some discussion around, is it possible that ERAS really only works at specialized centers or, a few centers? And, is there truly a dose-response relationship for gynecology as there exists in colorectal surgery? So this particular study, we looked at examining those questions. We aim to look at the association between compliance with the ERAS gynecologic oncology guidelines and postoperative outcomes. This was a large multinational study, over 2,000 patients in 10 hospitals across Canada, the United States, and Europe. We entered all the appropriate surgical details, took into account many covariates. These are some of the patient demographics. This was a 50-50 split between malignant and benign gynecology. There had been some question as to whether or not ERAS applies to general gynecology as well. 3/4 of the patients had laparotomy. The remainder had minimally invasive surgery. The take-home findings were that we were able to show that every unit increase in ERAS guideline score was associated with an 8% decrease in days in hospital among the low complexity patients and 12% decrease among patients with medium to high complexity scores. So starting to see the same signal in this group as was demonstrated previously in colorectal surgery. When we looked at complications, again, for every unit increase in ERAS guideline score, the odds of total complications were estimated to be 12% lower among low complexity patients. We did not reach statistical significance for the medium to high complexity group, I think simply because we didn't have enough patients in that cohort. So the main conclusions from this study were that improved compliance with the ERAS gynecologic oncology guidelines is associated with an improvement in clinical outcomes. And this does demonstrate a dose-response relationship as was previously shown in colorectal surgery. I'd like to now shift gears a bit. We've talked about the basics of ERAS. We've identified that ERAS is associated with an improvement in outcomes, not only in colorectal surgery, but also in gynecologic oncology and general gynecology. I'd like to now spend some time telling you how you can create your own successful program. And this can be achieved in 4 steps. The first step is formation of the ERAS clinical team. So this is crucial. Basically, these are all the people who are going to be doing the work in the program. So at minimum, this typically includes ERAS interested surgeon, anesthesiologist, nurse. We also typically recommend that you include a dietitian, pharmacist, physiotherapist, and even a hospital manager, because these are many of the people who will be able to make decisions around the protocol. And most importantly, choose people who you know are passionate about quality improvement. The second step is to create an ERAS protocol, and one that is that may need to be tailored to your local institution. After I wrote the guidelines, I heard from a number of people. We read the guideline, what do we do now, or how do we translate it into an actual ERAS protocol? Well, we answered that by writing this particular paper. So basically what we did here is we gave people specific examples of orders that they could use that are consistent with the ERAS guidelines. So while this is applicable primarily to gynecologic oncology and gynecology, this could serve as a basis for development of a protocol, for example, also in colorectal surgery. So we give examples in the preoperative optimization phase, for bowel preparation, preoperative analgesics, venous thromboembolic prophylaxis. We give lots of examples on what to use for prophylaxing against postoperative nausea and vomiting. Anesthesiologists are obviously a key part of the ERAS program. So again, we've provided some recommendations there. We also give examples on how to initiate early feeding, the appropriate opioid-sparing analgesia protocol, how to deal with fluids postoperatively, and then finishing up with activity and bowel routine recommendations. The third step is a crucial step, and it relates to the audit of compliance and outcomes. I've spent a lot of time with teams across the world, and they will often be very eager to tell me about how they do ERAS. And so I meet with a team. They tell me about their protocol. And then usually when I ask them whether or not they audit their program, unfortunately, in a number of cases, the teams are not doing this as adequately or correctly. So in many cases, we think we know, but audit is really the only way to get true control over your outcomes. And in some cases, it's a concept of, we don't know what we don't measure. This was a very important paper that was a joint statement by the ERAS and ERAS USA societies. Basically, as ERAS programs have proliferated internationally, there has been an unintentional effect of significant variation in how ERAS-related studies are reported and how ERAS programs are created. So this so-called reporting on ERAS compliance, outcomes, and elements research, or RECOVER checklist, is a checklist that contains 20 items that helps people to make the right decisions around ERAS program development, how to audit, and how to ultimately publish. So if you're interested in starting your ERAS program, this would be a really great place for you to start in terms of reading. But at the end of the day, the key take-home message in terms of audit is you need to be collecting patient demographics, surgical anesthesia details. Most importantly, as I indicated before, you need to be able to report on your ERAS protocol compliance at your starting point, but also after implementation. And during that time, you also need to know what's happening in terms of your length of stay and complications. Step 4 then is putting it all together and doing it according to the ERAS way. So the ERAS way, again, is having the team coming together regularly. Usually at the start of your implementation, it would be every couple of weeks. Some teams even meet weekly. And essentially what's happening is you're reviewing your protocol compliance and your outcomes. You're looking to see where you have low compliance to certain ERAS elements. And then your team, through PDSA or Plan, Do, Study, Act cycles, which are concrete action plans targeted towards areas of low compliance, you iterate towards improvements in compliance, which ultimately, as we have shown, is associated with improved outcomes. So this is a ERAS to-do list for you at your local institution. So you need to develop ERAS team, the people that are going to be doing the work. You need to create a specific ERAS protocol that clinicians at your institution will be able to follow. So again, for example, this could be done in gynecology or colorectal surgery. You need to audit or know what your baseline compliance is, so know where you're starting from, and also your outcomes. And then your ERAS team needs to meet regularly and through the use of PDSA cycles, start to increase compliance. And by doing so, ultimately, this will lead to an improvement in your clinical outcomes. So I'd just like to finish off the presentation now, putting ERAS into the current perspective, that which is COVID-19. This is obviously something that is changing everyone's area of work, and in particular, this has impacted the healthcare system. So, why now? Why is now the time for people to be thinking about implementing ERAS, and specifically to address some of the surgical backlog that exists? So this was an editorial that was written together with some of my colleagues, and essentially there was some work or reports from a British surgical collaborative or COVID collaborative that had estimated that there were more than 28 million surgeries canceled or postponed during the first peak 12 weeks of the pandemic. Now, obviously, since that time, there have been many more surgeries canceled, but based on those numbers, they had estimated that provided a 20% increase in baseline surgical volume, it would take nearly a year to clear that backlog. So many institutions were wondering how they would expand their surgical capacity, and especially how would this happen during a time when national and regional economies were under such pressure. We know that there's been significant financial impact also from COVID. So one of the key questions facing surgeons, anesthesiologists, and healthcare administrators is, where will hospitals find this increased capacity? And I think the answer truly is enhanced recovery after surgery. ERAS has been shown to reduce length of stay and complications, bringing down the need for hospital care from weeks to days without increasing the readmission rate, and importantly, minimizing the need for care in the ICU. We need to keep the ICU open for patients that are impacted by COVID. ERAS allows health cost savings between $5,000 to $8,000 per case in major surgery. And there's been some recent evidence out of Alberta that return on investment ratios now are approaching 7. Despite everyone saying they're doing ERAS, unfortunately, this is not the case, as length of stay from national data registries from even highly developed countries such as Germany, Japan, and France are showing length of stay after colorectal surgery exceeding 10 days, and in some cases even averaging as high as 24 days. So definitely there's room for improvement. I've spoken to many other clinicians and also healthcare managers, and I often hear, it's too hard to change practice, especially during this time. We don't have the money to spare for this program. But I will argue that we've witnessed how healthcare workers, under the pressure of COVID-19, they've actually proven that they can overcome the biggest hurdle to rapid improvements, and that's making drastic changes. So why can't we make those changes for surgery as well? So as I indicated previously, it's often the healthcare managers in a hospital that make decisions on when to implement certain surgical quality improvement initiatives. So I'd like to speak to them directly about the implications for ERAS during COVID-19. And I'll use the example of Alberta. So, we have a number of pathways in place, but, we have a long way to go, certainly in terms of being able to spread ERAS into all hospitals and surgeries in our province. So if we could imagine for a moment, if we did a rough estimate of eligible surgeries in Alberta being about 48,000 per year, and we take a conservative estimate of inpatient days saved, which would be about 1 to 2. So now that's 48,000 to 96,000 days saved. And if we take a conservative cost per day in hospital of $1,000, at this point, we're looking at system savings and capacity improvements. So about $100 million in savings. And obviously, there are some assumptions in there. But at the end of the day, I think we can make the argument to healthcare managers that they need to switch to ERAS, as ERAS implementation will definitely have a positive impact, especially during COVID. So in conclusion, I hope that I've been able to show you that ERAS is a global quality improvement program, changing the course of surgery as we know it. ERAS guidelines, combined with an ERAS team and an audit system, helps to integrate knowledge into practice, aligns perioperative care, most importantly, improves outcomes for patients, and is associated with significant cost savings to the healthcare system. And truly, ERAS is what we need right now to address the COVID-19 surgical backlog, and also importantly, to make surgery safer, faster, and better during this global pandemic. So thank you very much.
We want to thank you for joining us today on today's webinar and hope that you can join us again. And we also want to thank Dr. Nelson for his time today. If you have any questions pertaining to this presentation, we invite you to send them via our website, and Dr. Nelson will follow up with your response. Thank you and have a good day.